Before I forget, yeah, okay, go ahead.
We ready to start?
When you're ready.
Okay.
We can remain seated.
Do I have to go up there? No.
Yep.
Good afternoon, ladies and gentlemen. Welcome to the Lancet ESC session for this year, which is going to be on angina. It's particularly interesting that the Lancet has taken on this role for angina because many of you are actually too young to remember this, but back in 1867, that's 1867, not 1967, the first paper on use of amyl nitrate for angina was published in the Lancet by Thomas Brunton. So we have a history of that, so we're very pleased to take on angina again. So we have 3 talks, and the first talk today is going to be by David Newby. He's going to tell us about diagnosis of angina.
So first of all, I'm very grateful to have been invited to speak on this topic today, and my remit is, I suppose, the warm-up act for the next 2 speakers in terms of setting the scene of where we can treat our patients with stable angina. So what I'm going to do is take you through both the diagnosis and the prognosis associated with angina. So first of all, the usual declarations of conflicts of interest. I listed everything I could possibly think about, and some I didn't even know I was associated with, according to my institution. But I'd also highlight I was the chief investigator of the Scott Hart trial, so there will be some inherent bias in everything I tell you from now on. So first of all, I want to just set the scene in terms of heart disease. I don't think I really need to tell this audience that it's the biggest killer across the globe, and especially in those over 60 years of age. It's the major cause of death across the world. We often forget about disability in association with coronary heart disease and just think about mortality, but actually if you look at also the global burden of disease in terms of disability adjusted life years, coronary heart disease is up there as well. As you can see here, the 2nd and 3rd commonest cause of disability across the world. This is a major problem. We also know from perhaps more contemporary trials that there is an ongoing risk associated with angina. Here's data from the Courage trial, but you can see that people have really quite common events. 1 in 3 at 10 years will have a serious event, death or myocardial infarction. So it's a big problem. So how do we diagnose it? So I don't think the Lancet was actually around in 1768. I'm not sure. But William Heberden was accredited with the first description, really, of angina pectoris. And as I often teach my students, actually, angina is a choking sensation. And of course, Vincent's angina has nothing to do with coronary disease, but it's when you've got an infection of the floor of the mouth and you get choking, and so that choking sensation in the chest. And actually Heberden's, if you actually read this little extract, you'll see it catches all the key features of what is important in the diagnosis of coronary disease. We have, of course, developed just 1 or 2 extra terms since then in terms of how we describe angina, some of them useful, some of them less so. Obviously for today's remit, we're going to focus very much on stable angina pectoris. And the classification that we tend to use, I think, is a very useful one, the Diamond classification, which actually picked out the 3 salient points that Heberden described way back in the 18th century. So having substernal chest discomfort of a characteristic ischemic quality, provoked by exertion. I've actually added those brackets because I think emotional stress only induced chest pain is perhaps less discriminatory. Although if it occurs on exertion and with emotional stress, that is important. And again, relieved by rest. And classically, we can use this to categorize the types of angina into typical, atypical, and non-anginal chest pain. And actually, this has stood the test of time, 40 years now, but certainly from the Scott Hart data, if we looked at just the symptoms, the added value to diagnose obstructive coronary disease, actually having the presence of typical angina really does enhance the cardiovascular risk scores in terms of whether you do have obstructive coronary disease. So just the simple history is very, very powerful. Of course, we also have not just the character and the diagnosis of the symptom, but the severity classification Again, tried and tested now, the Canadian Cardiovascular Society, very useful, used in routine clinical practice across the world now, and is now, I think, a cornerstone of our clinical assessment. And indeed, having got the history, we then move on to the examination, which for coronary heart disease isn't very informative in the direct sense, because of course you can't see whether someone's got coronary heart disease or not. But you're looking for the risk factors, you're looking for exacerbating factors, and evidence either sort of circumstantial evidence with vascular bruits or alternative causes of angina. And of course today, just to be clear, we're talking about stable angina pectoris due to coronary heart disease. That's the focus of what we're discussing. And actually, if you look, and this is from the European Heart Survey of Stable Angina, it's very interesting that a lot of the simple clinical factors are very good predictors of risk. I think I would like to highlight a couple of these, in particular duration of symptoms. New onset of symptoms is very important in terms of risk. Here this is the inverse, I suppose. This is long-standing symptoms, but also perhaps not unsurprising, the severity of the symptoms. So the symptoms are very important in terms of how we are assessing the risk of the patient. And actually when it comes to clinical examination, there's not an awful lot that adds value in terms of risk stratification on physical examination. Now if we turn to the guidelines, we've taken our clinical history and examination, they list the various factors here, which again are helping to identify risk factors, also how we might manage exacerbating factors. I want to highlight a resting electrocardiogram. Whilst it's commonly normal in patients with typical angina, of course any abnormality is a risk marker, as indeed is the echocardiogram. A chest x-ray really is mainly of merit in terms of differential diagnosis and doesn't carry much in the terms of weight of risk. I think this much maligned test, the exercise ECG, is one of the best, if not the best test that we have, and I'm still not sure why we don't use it more. For me, it's not just about the diagnosis, it's an objective test of the patient's symptoms. The patients will often tell me they can hardly walk the length of themselves and yet they do 10 minutes on the treadmill. Or they tell me that they can walk for miles and within 2 minutes I'm getting the defibrillator out because they clearly are completely exhausted and having problems. So it's a great objective assessment of what the patient's history is. Because patients struggle sometimes to communicate to us, and of course that's part of the art of a doctor, of course, but nevertheless patients' histories are not always that clear. It also is an objective test of exercise-induced symptoms, which is the key cornerstone of the triad of symptoms. Is it exertionally induced, and is it reproducible? And that's before, so all of these things are incredibly useful before we even think about whether there's an ischemic ECG at the end of that, or whether the blood pressure has gone up or down, etc. So I think it is the cornerstone of what we should be doing. The European guidelines give it 1B. It's the first test it recommends. It does go on to talk about using other tests, which we'll come on to, but for me this is the critical test. It's easy to do in the clinic, very simple, very straightforward, very powerful. Now, of course, there are other ways of stressing your patient. I'm not suggesting for a minute you should be inducing the one on the left-hand side of the slide, but there are various different ways of looking at how a stress test can be implemented. I think everyone acknowledges that physical treadmill testing is probably the best form of stress, followed by the bicycle and followed by pharmacological therapy in terms of discrimination. There is variability in the response to pharmacological agents, so you might have the best discriminating test in the world, but if the pharmacology is variable in its response, you're going to be challenged by that. Putting all that aside, of course, there are three other main imaging stress imaging modalities that we use. Myocardial scintigraphy, be that PET, or as in this case, or SPECT, has been used across the world to look at inducible perfusion deficit to help us diagnose angina pectoris. Of course, it has limitations, principally the radiation involved, sometimes attenuation from overlying breast tissue, etc. And people have argued about the pros and cons. However, it is a very robust technique, had a huge body of evidence behind it, and has been entrenched in our practice for many, many years. The alternative of stress echocardiography avoids the radiation exposure, gives us nice quantifiable images. Of course, you have to have severe enough disease to induce enough ischemic dysfunction of the left ventricle to be picked out. The challenges are that not everyone can be imaged. It requires a lot of expertise in terms of the person performing the test, and very close attention to detail in terms of pharmacological stress, although many stress echocardiographers do favour exercise. Obviously, you can't actually, it's challenging sometimes to perform this, but there are various ways of doing it. But in a significant proportion of patients, you will get suboptimal images. Suppose the latest kid on the block is myocardial perfusion imaging with magnetic resonance, which, of course, again, has no radiation exposure. Gives us beautiful images with much better resolution, perhaps, than scintigraphy. The downsides, of course, as you're aware of the claustrophobia, our patients often have devices implanted, and again requires a lot of expertise in terms of interpretation, and isn't quite as quantifiable as the scintigraphy approaches. So we have these lovely techniques, and when I sit with an echocardiographer, a nuclear medicine physician, and a magnetic resonance physician, this is usually some of the conversations that they have. It depends which technique you prefer as to whether you're the guy in the middle or you're the guy on the end, but nevertheless there is a lot of passionate belief of each people as to which is the better technique in terms of the stress imaging approach. Now, there have been some tests, some studies doing the assessment, and I think this is, for me, one of the best that has compared the different imaging techniques. John Greenwood's excellent work from Leeds. And I think the CE Mark study there demonstrated a clear benefit of the diagnostic accuracy with magnetic resonance. Of course, the nuclear medicine fraternity will say, well, maybe the guy that did the images wasn't as good as the guy that did the MRI. And so we start to have these sorts of conversations, not about which technique is better, but which centre is better at which technique. And so it then becomes rather confusing. And actually, if you look at the guidelines, the European guidelines, when you look at all the various techniques and you line them up and look at their specificity and sensitivity, overall, they're all about pretty much the muchness, except perhaps the exercise ECG. And of course, the Achilles heel here is that it may well give you a lot of false negatives with the exercise test, and we recognize that. But of all of these tests, they all have a false positive and a false negative rate that is not insignificant. For the European Society, the recommendations are that you should calculate the pre-test probability and select your test according to that. But they do suggest that stress imaging is preferred above exercise ECG where local availability and expertise permit. And that's sort of a rather soft, in my mind, guidance. So how do you select which of your lovely tests you're going to pick, which one is going to be best? So if we look at the American guidelines, in actual fact I was quite surprised when I was looking through the American guidelines that actually it looks like you should all get an exercise ECG according to the American guidelines. Yet when I speak to my American colleagues, they all either get an angiogram or a myocardial perfusion scan. So I'm a bit confused, I have to say, when I look at this. There are various very sensible decision trees here about whether the patient can exercise, whether previous revascularization, whether the ECG is interpretable. But for a new presentation of query angina, you usually rattle down that list and end up with an ECG, a stress ECG. So I'm slightly perplexed as to how the practice is not through. There is, as you can see, this algorithm is quite complex, and it does feature all of the different types of different imaging techniques, and it's therefore perhaps not surprising that people sometimes find it confusing as to which test to choose. But I suppose also there's not really evidence on which to make that recommendation, which is why the guidelines have been frustrated in how they do it. The other thing I should highlight, that the American guidelines, the only 1A recommendation it makes is for an exercise ECG. The other stress tests are 1B. The European guidelines are all 1B, exercise ECG and other stress imaging, which I find very interesting. So here's the European guidelines. So you have to calculate your pre-test probability, that's what PTP stands for, and then you can go through all of that, or you can ignore it and have a CT angiogram if your pre-test probability is between 15 and 50%. So if you actually try and pick this apart, the rationale for this is really that if your pretest probability is less than 1 in 6, or more than 1 in 6, then it's quite clear. If it's less than 1 in 6, you don't need any testing because you might have a much higher false positive rate. And if it's greater than 1 in 85%, you're better off just getting on and having an angiogram perhaps, or a more invasive investigation, because if it's negative, it's probably a false negative. And then you've got the grey zone in between. Now, if we're going to use this, it's very important that the pretest probability helps you. So this is the chart that's in the guideline. The American guidelines have a similar chart. And the color code here is the blue is for an exercise ECG, or where there's local availability and preference, you could do a stress imaging. The salmon colored one is you should do a stress imaging test. And the red is telling you you've got coronary disease, don't do any other tests, and just get on with it. But actually, these are largely overestimated. So we looked at this in the Scott Hart trial when we looked at coronary angiography and compared, using that chart, what the pretest probabilities were. And as you can see, both the European and the American guidelines vastly overestimate the pretest probability, which means we are over-investigating a lot of patients. And that's not just me saying that. This is the CONFIRM registry. They proved this 4 years ago. And also showed that the risk estimation that people are attributing to the likelihood of obstructive coronary disease, the tools are overestimating. And I think, if I'm being fair and balanced about this, it's because we all worry about missing the diagnosis of coronary disease. And so where our confidence intervals are at the higher end, so we'd rather overestimate than underestimate the risk. And perhaps that's why it's reflected in the way that it is. And there is a problem here, because this is data, UK data, looking at the outcome of patients that come through the clinic. First thing to say is that cardiologists are very bright people, and they're very clever because they can pick out the risk people. So there's a seven-fold hazard ratio. The cardiologists can pick out the high-risk peoples very well. But the majority of people are deemed not to be high risk, and so if you actually look at the proportion of patients, it's only a quarter that are the high risk and the 3/4 that aren't. But the 3/4 that aren't do still contribute a third of those that then go on to have a myocardial infarction or a fatal myocardial infarction. So die from coronary disease or have a non-fatal MI. So we're missing 1 in 3 of those. So we do need to do better. This is coming back to the European Heart Survey, and I think this is adding all the clinical factors and all the investigations in and seeing which are the independent predictors of fatal and non-fatal MI. And as you can see, abnormal LV function, ECG changes are in there. But actually, when it comes to a positive stress test, it's actually, as you can see, it crosses the one line. It's not actually predictive. I should point out that that means you've had a positive stress test and a normal angiogram, or a positive stress test without any further tests. So I don't want to give the impression that a positive test is not helpful, because we all know that is true. It's very helpful. But what this, and this is the same sort of data displayed graphically, the take-home message for me from this is that you need to know whether you've got coronary disease or not. Do you have coronary artery disease? Yes, it's helpful to stress the patient and understand the relationship between the symptoms of angina, but if you're trying to prevent future events, you're looking at prognosis, what you need to know is, do you have coronary artery disease, yes or no, not inducible ischemia. And the other part of this is the test itself, of course, has no association with improvement. It's whether it's the consequences of that investigation, and does that mean you get treated. And if you look at those that got treated in the European Heart Survey, their outcomes were consistently better if they received treatment. No surprise, I suppose. So, I want to now turn to CT coronary angiography. This is a patient, a young patient who had atypical anginal symptoms and was being managed medically and would have a calcium score of 0. And as you can see, they have a critical LAD lesion. The blue circle is actually adjacent diagonal artery, just to show you that the lumen really is incredibly restricted here. And obviously, this person went on to have a PCI quite quickly. But seeing is believing, I think. So we have had 2 trials this year to address this issue of CT coronary angiography in the context of angina pectoris. The first one I'm going to talk about very briefly, and I'm going to spend a disproportionate time talking about Scott Hart, shamelessly. But the PROMISE trial was a very big trial in the United States and Canada that recruited 10,000 patients to look at the comparison, and I think this is important, comparison between anatomical versus functional. Which is the best first test? Now, this population of patients was intermediate risk, and as you can see, the primary outcome of the trial was identical in the 2 arms. Now, the primary outcome was quite a complicated primary outcome of death, all-cause death, non-fatal MI, hospitalization for unstable angina, anaphylaxis, renal failure, and bleeding. So quite a complex mixed bag of things, and when you look at the primary output and the breakdown, you can see that all-cause death was identical, and arguably what a CT scan will tell you is not necessarily all-cause death, but coronary heart disease death, because it's not going to impact necessarily on other factors. Non-fatal MI was a trend, if you're being optimistic, like I tend to be, in the right direction. Hospitalization for unstable angina, the opposite direction, and procedural complications were minimal. So overall, this was viewed as a neutral trial that either approach is potentially acceptable. We performed the Scott Hart trial, which was published at the same time at the ACC. But here, it was a slightly different approach that we took. And this is the protocol that the patients went through. And it's much in line with what we've already described. And everybody attended the cardiology clinic, had a clinical assessment, had an exercise ECG as appropriate. Initiation of treatment and therapy was decided upon. And only as they were running out the door, although they weren't running by the time we got hold of them, they consented to take part in the study and were randomized to have the addition of a CT scan or no CT scan. And we actually recruited 50% of patients that were eligible as they left the clinic, so a huge proportion of patients, very generalizable. And then they had their CT scan, they came back for the attending clinician review, and at 6 weeks we asked the clinician what they had changed. Had you changed treatment? Had you changed tests? How certain were they about the diagnosis? And what we wanted to demonstrate was that if we look just at the diagnosis of coronary heart disease, you're 2.5-fold more likely to be certain that this person has or has not got coronary heart disease. Perhaps not surprisingly, given that we know that small non-obstructive plaques are common, the overall frequency of the diagnosis of coronary heart disease went up a little bit. When it came to the diagnosis of angina due to coronary heart disease, the certainty again doubled, nearly doubled. But interestingly, perhaps paradoxically, it actually reduced the overall diagnosis of angina due to coronary heart disease. And I think that comes back to my earlier point that we're keen to overdiagnose and not miss anything. And so a lot of these people were given the benefit of the doubt and was treated rather than not treated. And ultimately, the CT scan will give you the confidence to know that actually you didn't need to treat this person for angina. We've seen this example already. This is an example of a patient that was going for an invasive coronary angiogram who had typical anginal symptoms and didn't then have that angiogram because they clearly had normal coronary arteries. And the rate of normal angiography was seen in PROMISE and in Scott Hart was markedly reduced. And in Scott Hart, it was reduced nearly 3-fold down. So you were 3 times less likely to actually have a normal coronary angiogram. The corollary was also true. You've seen this example, but the rate of angiography showing obstructive disease increased significantly when you were pre-scanned with a CT coronary angiogram. So it was finding the right patients. The CT angiogram was indeed accurate and finding the disease. Did it change things? Yes, it did. I've told you it increased the diagnosis of atherosclerotic disease, so preventative therapies were cancelled in those with normal, but more were started. And given that I've told you that the diagnosis of angina was less frequent, more anti-anginal therapies were cancelled than were actually started. But again, that gives you a flavour of the number of patients that actually had their treatment changed by the CT was quite considerable. This was not the primary endpoint. The primary endpoint was diagnosis, but the main hard clinical endpoint, and we were mostly focused on coronary heart disease death and non-fatal myocardial infarction. And as you can see, it showed a clear trend towards a reduction in events with the CT scan arm. You will also notice this rather interesting phenomenon occurring down here, where the Kaplan-Meier curves are overlapping and then diverge. Now, part of that explanation is the delay in doing the CT scan. The CT scan took on average 12 days a median of 12 days after the clinic attendance. The result then has to be fed back to the clinician, who then has to write to the GP, who then has to prescribe the drugs. And we looked at this. So CT coronary angiography rates were identical. There was a slight early excess, but as time went by, the overall rate of invasive angiography was the same, and yet we diagnosed more obstructive disease and less normal angiograms. So we were more carefully selective. On top of that, the revascularization rate trended to be increased, again reflecting the fact that we saw more obstructive disease. When it came to drugs, we can see that antiplatelet therapy and statin therapies were increased markedly. And again, look at this curve. It takes a while for these drugs to actually get prescribed. And the median time for antiplatelet and statin therapy prescription was around 50 days from the clinic attendance. So it took a month and a half for actually the consequences of the diagnosis to be made. So we did go back and cut it at that median time point. We can argue whether that's the right time point, but we did cut it. And there you can see that its overall effect size estimate, not that my statisticians like me doing this, I hasten to add, but the effect size estimate would suggest that if you would implement it immediately on the day that you saw the patient, that maybe you could halve event rates. So Scott Hart, I think, in terms of what it showed was that on top of stress testing, albeit not the best stress testing modality, you can clarify the diagnosis, you can change your investigations appropriately, and you can change treatments that does appear to affect outcome. When I compare the two trials, because one was negative and one was neutral, and I think Scott Hart, I'd like to think, was much more positive. It may reflect the disease population. These weren't all patients with what we would all understand as angina. A quarter of them didn't have angina in the PROMISE trial. The PROMISE trial deliberately went for the intermediate group. Their pretest probability or likelihood of having a coronary disease event was slightly higher than the Scott Hart trial. In the Scott Hart trial, virtually everyone, the vast majority of people had some form of stress test, whereas obviously in the PROMISE trial, this is the data for the stress arm only. Of course, the CT arm did not get this. Again, harping back to the American guidelines, we can see that the practice is to do myocardial perfusion scanning rather than stress testing. But when you actually look at the ultimate disease in this population, Scott Hart had a quarter of patients had obstructive disease, around 10% in PROMISE, and the revascularization rates reflect that. And again, reflecting that is the MI rates that I've extrapolated out to 10 years here between the two trials. So clearly PROMISE was a much lower risk group, albeit our largest population, and arguably an intermediate probability. So for me, it's about looking at the symptoms, doing an objective assessment of the symptoms, and then asking the question, do you have coronary heart disease? And I think there's also an important aspect to this in that this is the CONFIRM registry, and this is outcome and events. This is non-obstructive disease. This is single vessel obstructive disease, very similar event curves. So if you've got non-obstructive coronary disease, you have an outcome event rate that's very similar to single vessel disease. And of course, stress tests will not diagnose this. Stress tests do not give you non-obstructive disease. This is the data from the Scott Hart. We just looked at the CT scan arm, looked at event rates, and again, very similar. Non-obstructive disease is not benign. It has a significant MI rate, and that will be missed by stress testing imaging. So this is Dave Newby's approach to investigating patients with stable angina. It is compatible with the guidelines, with the exception of the CT angiogram. I think we have now got more evidence. The evidence base is graded 2B, 2A in the guidelines, but now we have that evidence to try and look at this And this is the sort of algorithm that I think makes sense for our patients that we're seeing. So just to summarize, coronary disease is a major problem, causes a lot of death and disability across the world. I personally think that we should be looking at combined functional and anatomical assessments early in our patients. We now have technologies that can do this non-invasively. And I think when we do have that proper full assessment, we can appropriately give people the right treatment to the right patient, and it can improve their outcomes. And I don't think we should dismiss the fact that actually stopping treatment in people who don't need it is actually very beneficial to our patients too. Thank you for your attention.
Thank you. We have to move to the next presentation, which is focusing on pharmacological therapies, and that will be given by Magnus Ohman from Durham, United States. Magnus.
Frans, Stuart, thank you very much for inviting me to participate in this session. And I'm going to be going through the medical management of chronic angina. As opposed to the prior speaker, I will cover in therapeutics the area between 1950 and 1980, just to put it in perspective. These are my disclosures, both for research and as a consultant. So I'm going to cover basically 4 areas. First, I'm going to talk a little bit about the therapeutic goals for the treatment of chronic angina in patients with coronary disease. I want to stress that we're dealing with coronary disease. I'm going to go through very briefly the standard anti-angina therapies that are available to us, beta blockers, nitrates, calcium channel blockers. I'm going to talk a fair bit about the emerging anti-angina therapies and divide them into 2 sections, physiological or metabolic, and I'll explain that a little bit later. And at the very end, I will touch a little bit about experimental anti-anginal therapies, much about angiogenesis and stem cells to improve angina. I want to mention that for those of you who would like to take a break, this is actually all covered in this paper, so you can all go to sleep, go to the Lancet booth, pick it up, and you'll get to see everything that I'm going to be talking about. My co-author on this was Sten Husted, who couldn't be here today, and so I owe him a lot of gratitude. So what are our objectives when we treat patients with angina? Well, we really want to do 2 different things. We want to improve quantity of life, and we want to improve quality of life. And there's slightly difference. In the quantity of life issues, we have to prevent MI and death. But in the quality of life, we really have to reduce ischemia and relieve angina to make patients feel better and be able to do more. So what is the ideal therapy in this setting? Well, the agent should objectively reduce ischemia, and to get to the objective part, they should be able to exercise further without suffering angina, either with or without existing anti-angina therapy on top. The agent should reduce clinical angina. The agent should reduce clinical events caused by angina, such as hospitalization for angina or need for revascularization. And finally, the agent should have an established safety profile with no adverse effect on death or MI. So why is exercise testing so important? Well, this slide actually gives a hint to this. It actually tells you what happened during duration of ischemia and the physiological EKG and the symptoms that occur. And what you will see is that angina is the last manifestation of ischemia. And therefore, if we only look at angina, we cannot really objectively, because we have ST changes occurring before this. And many episodes of ischemia never become painful. So that's an important observation. So how are we doing on this? Well, the agent should objectively reduce ischemia. Most agents, as I will review with you, satisfy this. The agent should reduce clinical angina, and most agents that we have available to us also satisfy this. Now, what about the last 2? The agent should reduce clinical events caused by angina. Very few agents do this that have been studied. And the agent should have an established safety profile with no adverse effect on death and MI. And unfortunately, as I will share with you, this is largely unknown. So let's talk a little bit about the standard therapies. Well, let's start with nitrates. You're all familiar with all these forms of nitrates, from short-acting sublingual to long-acting nitrates as shown here. The key and the only reason for showing you this slide is that it's very important that you try to avoid tolerance by having an off period. And you can see in this outline how long you need to be off nitrates in order for it to be most successful. And there are no outcomes trials with nitrates, as you can imagine. Now, what about beta blockers? Well, we have also a broad array of those. They differ in adrenoceptor selectivity, lipid solubility, bioavailability, elimination half-life, and renal excretion. So the most selective beta-1 selectivity is bisoprolol, metoprolol, atenolol, and nebivolol. Lipid solubility tends to be carvedilol, labetalol, and propranolol. The bioavailability is really highest with bisoprolol and sotalol and nebivolol, so there's some of the newer agents. And you can see the elimination half-life is on average in the ballpark of about 6 to 10 hours, some rare cases over 10. And you can see that renal excretion, atenolol, stands out, which is of course an issue in the elderly. What about calcium channel blockers? The most common agents are shown here: verapamil, diltiazem, nifedipine, amlodipine, and felodipine. Bioavailability varies quite a bit. Elimination half-life, the longest with amlodipine, so once a day. Systemic vasodilatation with nifedipine, amlodipine, and felodipine being the most common one. Coronary vasodilatation, once again with the same 3 agents. Myocardial contractility, as you're all familiar with, tend to be more with verapamil, diltiazem. And changes in heart rate, really verapamil, diltiazem reduces heart rate, nifedipine increases it, and the other 2 agents really have no major effect on this. AV conduction, which is important when you combine therapy, is predominantly seen in verapamil, but a little bit seen also with diltiazem. Now, how are these agents when you compare beta blockers with calcium channel blockers? And this meta-analysis of all the clinical studies, you can see that both of these agents, beta blockers and calcium channel blockers, are about the same. They improve exercise time with about the same duration. When you look at angina episodes per week, interestingly, the one that we're most nervous about using in coronary disease, namely nifedipine, tends to reduce angina a little bit more compared to the other agents. And beta blockers are pretty much equal to all the other ones. Now, I've stressed with you the importance of outcomes data. And in fact, there are 59 short-term studies and only 2 long-term studies with these agents. And you can see broad confidence intervals and no real significant difference in either agent favoring either calcium channel blocker or beta blocker, so similar type of effect on cardiac or death or MI. Now, we frequently talk about the fact that we need to use more agents than one, and this is the only randomized trial that I'm aware of that looked at long-term use, monotherapy with amlodipine or atenolol versus the combination. And the conclusion from these investigators, shown in the table below, is that for individual patients with stable angina pectoris, combination of a beta blocker with calcium channel antagonist is not necessarily more effective than either drug given alone. And this is pretty powerful given the fact that this is a randomized trial. Now, what about other information about beta blockers? Well, we have this outcomes data from a propensity analysis of using beta blockers in the REACH registry. Here you can see this is not randomized, but if you look at the primary outcome, they look about the same if you had a prior MI, known CAD without MI, or risk factor without MI, maybe a little bit higher risk with beta blockers here. But if you look at the secondary outcome, you remember here dealing with revascularization or rehospitalization, here it actually trends in the wrong direction in this propensity analysis. So long-term safety in the non-post-MI population is less clear, and this is 4 years of follow-up. This overwhelming slide is not here to go through with you, but as all of you know, all of these agents have multiple side effects, which makes the reason for combining different therapies to find the best strategy, the best approach. Now, what about the emerging anti-anginal therapies? And I'm going to divide those into physiological or metabolic. So what are physiological anti-angina agents? Well, they are either affecting heart rate or vascular tone. These agents are Ivabradine, nicorandil, or milsodipine. The metabolic anti-angina agents, they actually affect energy substrate in the myocardium to alter metabolism and reduce oxygen needs, so completely different. They typically do not affect heart rate or blood pressure, and the agents that fall into this group is ranolazine, trimetazidine, perhexaline, allopurinol, and mildronate. One thing that all of these agents have in common is that the emerging anti-angina therapies are not available in all parts of the world, and I recognize this is a big international meeting, so you will see agents that are not available to you in your country. So let's start with Ivabradine. It selectively inhibits the IF channel that regulates pacemaker activity in the SA node, reduces heart rate both at rest and exercise, and is most effective when rest heart rate is over 70. It's generally well tolerated. However, the safety concerns include development of A Fib and possibly higher adverse events of death and MI in a large study that I will share with you. It's available in most countries, but only approved in the US for heart failure management. Here is the exercise data, the largest trial on Ivabradine, comparing it to atenolol, where you can see this is a non-inferiority trial, and actually it is non-inferior to atenolol, but it's also not better. So this is an agent that has some value if you have some intolerance to beta blocker, for example. Now, what about the outcomes trial? This is from the stable coronary artery disease without clinical heart failure trial. And here in the subgroup of the class 2 angina patients, you can see the 12,000 of them, and here the signal is actually for a higher rate of death and MI during the follow-up period in this trial with a p-value that is 0.03 and an interaction p-value as shown. So here we have some concern what it might lead to. Now, what about nicorandil? It's a nicotinamide ester with dual action. It opens ATP-sensitive calcium channel, dilates arterioles, may mimic ischemic preconditioning. Nitrate moiety also dilates venous vessels. Compliance may be poor due to headaches and hypotension, so low blood pressure. Drug tolerance for anti-angina effect has been documented, and it is ineffective with sulfonylureas in diabetic patients. It's mostly available in English-speaking countries, but not in the US. Here is the large Iona trial published in the Lancet showing actually a reduction in cardiovascular death MI or admission with recurrent chest pain, a significant finding in favor of nicorandil despite the fact that there was some patients who dropped out. Now, what about milsodipine? Well, this is a nitric oxide donor which dilates venous vessels and dilates epicardial vessels. It's a prodrug metabolized in the liver. Tolerance is less likely to develop compared with organic nitrates, and both short and long-acting preparations available. Common side effects include headache, no large-scale safety and efficacy studies, and only available in some countries in the world. And here is the largest study on this agent showing on the left the placebo-treated patients, those with many attacks, moderate, small, and no attacks or very few attacks of angina. And when you compare the shaded areas, you can see a fairly significant reduction in clinical angina, predominantly seen in the most symptomatic patients. Now, if we're going to go through all the different exercise studies, which I will not have time to, but they are in the paper, you can see that, generally speaking, Ivabradine, nicorandil, milsodipine actually increase total exercise duration, and they reduce self-reported angina. Now, what about the metabolic agents that I've talked to you about? I'm going to turn to ranolazine first. It's an active piperazine derivative that reduces calcium overload in the ischemic myocardium by inhibition of the late sodium current that serves as an exchange for calcium in the ischemic myocardium. It has several drug-to-drug interactions through the cytochrome P450 system, so many warnings about which drugs you can use this with. It prolongs QT interval by an average of 2.4 milliseconds. Common side effects are dizziness and nausea. It's available in some countries and in the US. Here is the study that I looked at this for angina frequency. You compare this now on the background therapy of amlodipine. So patients were amlodipine plus placebo on here compared to those with amlodipine on ranolazine. And what you can really see is that there is a fairly modest effect only in reducing angina. Now, if we turn to a more long-term therapy trial in the face of diabetes mellitus, this is the Teresa trial published now a couple of years ago. Here you can see that while angina is improved with ranolazine, the effect is fairly modest, but it's fairly consistent over time. And another important part of this slide is actually shows you that even patients who are treated with placebo get less angina over time, probably because of adjusting of lifestyle issues. This trial has been studied in an outcomes trial in a post-ACS setting, showing here overall no effect on death and MI. On the isolated endpoint of recurrent ischemia, there was a reduction of about 13% relative reduction, but the overall trial was neutral, showing no clinical benefit with the agent of ranolazine. Now, there was a subgroup analysis that were pre-specified because, as you can imagine, there were a number of patients that had chronic angina before they had the ACS event. And in this group of patients, which actually represented nearly 1,000 patients in the study, you can see some benefit here with ranolazine versus placebo over long-term for the primary endpoint, recurrent ischemia, the need for new anti-angina therapy or worsening angina, so all favoring this approach in this setting. You will hear more about this agent at the TCT, where the late-breaking clinical trial of River PCI will be presented, so you will have to stay tuned for that. So we'll have more on that agent there. Now, what about finally the metabolic manipulation of the energy supply in the heart to reduce angina? So on the left-hand side here, you can see the aerobic conditions where we typically use a lot more fatty acids than glucose to generate ADP for muscle contraction. However, under ischemic conditions, we have much less fatty acid available, and glucose forms a more important part, which actually therefore reduces the oxygen, which actually causes the ischemia to occur. Now, these drugs, and what I'll show you on the next slide, actually affect this by reducing the fatty acid and restoring this balance somewhat. And these fall under a number of different agents, but the most well-known ones are the CPT inhibitors, which are perhexylene, amiodarone, and trimetazidine, and that all work on the CPT receptor. Mildronate, another agent, works on the Acyl-CoA inhibition, thereby reducing the energy required. So, perhexylene, probably the oldest drug I will share with you, shifts myocardial substrate utilization from fatty acids to carbohydrates through inhibition of CPT1, resulting in increased use of glucose and lactate. Genetically determined slow hydroxylators lead to toxicity and hepatic accumulation and peripheral neuropathy. Drug monitoring is essential. Ideal levels are shown on this slide. And this drug is restricted use in many countries and not available in most of the world. Having said that, Harvey White published his paper in 1983 showing actually that there is a dose response to reduction of angina with perhexylene in a very early study prior to coronary artery bypass grafting, so the episodes of angina were improved. What about trimetazidine? It's a selective inhibitor of 3-ketoacyl-CoA thiolase, which causes a shift of energy substrate away from fatty acid to carbohydrate, leading to less O2 requirements for ATP generation. These studies are mostly being carried out in men, and the common side effects include nausea and other GI symptoms and muscular cramps. It's available in many countries in the world, but not in the US. I guess you probably see the theme here. Here is a meta-analysis of the efficacy and tolerability of trimetazidine in stable angina. It shows a reduction in weekly angina, which is significant, but there's only a modest effect on the exercise duration, which is only modestly improved in all the studies. What about mildronate? It's a selective inhibitor of the GBBH, the enzyme that catalyzes carnitine biosynthesis from the liver, which reduces Acyl-CoA, which in turn reduces fatty acid oxidation. So different enzyme, but slightly different aspect to it. There are very few studies, mostly from Eastern Europe. Side effects and long-term safety are not well established, and these agents are really only available in these countries listed here. Having said that, it actually looks like mildronate actually can improve exercise tolerance in patients with stable angina. You can see here before treatment and then following treatment in white is the mildronate. It actually improves quite a bit with this particular agent. Finally, we have allopurinol, of course, treated and used for gout, but it has been studied in this one study in patients with chronic angina. It's a relatively small study of 65 patients, and there is no slide here telling you how it works, because as the authors point out in this paper, we don't know how it works. But it does actually improve exercise tolerance in this otherwise very elegant study, but there's only a marginal reduction in clinical angina. Now, if you look at ranolazine, trimetazidine, and perhexaline for exercise duration and self-reported angina, it's very similar to what I said before. Improvement in exercise tolerance for all of these agents and a reduction in chronic angina with all of them. How about some experimental anti-anginal therapies? And I'm going to talk mostly about angiogenesis and growth factors. But before I get into this, I should just point out that a number of other agents have been used. Amiodarone actually was first developed as an anti-anginal agent, and it improves exercise tolerance and reduces rate pressure product, therefore will be very successful in treating angina. I'm not recommending that you use this agent because it had, of course, toxicity and a lot of side effects. You can see that omapatrolate, L-arginine, transdermal testosterone have all been shown to improve exercise tolerance and reduce angina, but they all have issues with them. Finally, a therapy that is probably not available or not in your thinking is chelation therapy, which is actually used in North America, and it's intravenous administration of EDTA plus vitamin therapy for patients with established coronary disease. Now here we have a reverse situation, no improvement in exercise duration, but actually lower rate or revascularization, i.e. less clinical angina leading to revascularization with chelation therapy in this setting. So there is a second study being planned for this. Finally, just one word about statins. There's one paper have been published that suggests that actually lipid-lowering therapy with atorvastatin can reduce angina attack in this elegant study. I'm not recommending that you use this as an anti-angina, but of course, part of the package of treating patients with coronary disease is to add statins, and this is, I think, is of some interest. Now, what about growth factors? Well, there's been a number of these studies, and I'm not going to have time to include them all, but this is an interesting looking at FGF, growth factor, to stimulate growth of blood vessels. Several trials here, but combined analysis of the Agent 4 trials. And in this placebo-controlled intracoronary injection of FGF, you can see for men, there was an improvement in exercise duration, but that was also seen in placebo. On the other hand, on the right-hand side, there was a fairly different response in women, where actually women had a more of a therapeutic response because the placebo group behaved just a little bit differently than it did in men. So this is still a consideration. Even if you inject the endothelial growth factor, as in this trial, straight into the myocardium in patients with severe angina pectoris, these investigators could not find any benefit or reduction in perfusion defects, suggesting that maybe growth factors is not going to be the answer. Now, what about the infusing stem cell therapy to create angiogenesis. There has been a meta-analysis of all the different trials. I want to point out, though, that there's only 400 patients studied overall. But you can see in these combined analysis from these several trials of 400 patients, there actually is a fairly important improvement in the exercise duration seen here in this meta-analysis. So maybe this is something to consider for the future. The largest trial on this topic, the RENEW study, has completed their enrollment. This is the design manuscript, and they are in the follow-up phase. So we will hear more in this trial whether CD34 positive stem cells actually improve outcomes. So this is the beta blocker and calcium channel blocker recommendations from the European Society Guidelines from 2013 that David showed earlier. And it basically defines that beta blockers or calcium channel blocker should be used first, and then a number of other therapies could be added on, such as some of the agents I've described to you. It also points out that you need to consider event prevention with lifestyle changes, as well as aspirin and statins. I think this is a helpful component, but we have really come up with a slightly different approach to how to manage patients, because we believe that actually combining metabolic as well as physiological agents may offer a little bit more value. So we really define patients by their baseline physiology, if they have an abnormal or a healthy baseline physiology, and you can see the parameters that we say: heart rate above and below 60 and a blood pressure above and below 100. In those with healthy physiology, you can of course use a lot of the standard agents, the physiological agents, to treat the patients for angina, but also optimize heart rate and blood pressure. And after that, you can actually switch to a metabolic agent to see if you can get better outcome. On the other hand, for patients who have low blood pressure, low heart rate, you really can't use the standard agents because you really have no move to go. So there you need to start straight with a metabolic agent to what you have available to you in your country. So in conclusion, therefore, the majority of agents tested for the treatment of angina can improve exercise time and reduce angina. Combining physiological with metabolic agents for patients with symptomatic angina may be a preferred strategy, but we have no outcomes trial to tell us so. The lack of large-scale clinical trials to define the best clinical strategy prevents a firm recommendation to be made on anti-angina therapy selection. So we really don't have good evidence to how we should approach this group. Stem cell therapy may offer best strategy for angiogenesis, particularly if the large-scale trial proves positive, but injecting stem cells in patients with coronary disease is quite complex, and it's also likely to be very costly. The lack of newer anti-angina therapies is disturbing. In my review of the literature, we could find no evidence of a new agent in the last 5 years. And that's disturbing, because we have an aging population is more likely to be treated with medical therapies rather than invasive therapies. So my hope and my call to action to all of you is we need to develop more effective therapies for angina using adequately sized randomized clinical trials so we can define the best treatment strategy. Thank you very much for your attention.
Thank you, Magnus, for this overview. You introduced the last.
Okay, the third speaker is Roxana Mehran, who's going to tell us about invasive strategies for angina treatment. Roxana.
Thank you, Dr. Spencer, Dr. Van der Wert. It really is an honor for me to be here, and on behalf of my colleagues and my co-authors of this review series, which can be picked up as the last two speakers spoke, obviously Rafael Piccolo, Gennaro Giustino, myself, and Stefan Windecker, who unfortunately could not be here and should rightly be presenting this paper. It is important for you to note my disclosures. but to this particular topic, I'm an interventional cardiologist, hence invasive therapies rule. And so let's continue in that way. I wanted to begin by some of the limitations we currently face, and we had two excellent speakers before me talk to us about where we stand with ischemic heart disease regarding diagnosis and medical treatment. And the true fact is that limitation of our current evidence-based practice and the way we use it is that we know that what we're looking for in our patients and in our clinical trials is that some patients have a good outcome, some have an intermediate outcome, and some have a bad outcome. And if we look at the general population and in the clinical trial results, we have a mix of those. But when we report those in our prestigious journals, what we see is a mean treatment effect. And frankly, there is no patient, a single patient, with that mean treatment effect. And so the real-world outcomes and the treatment difference is one that we really do need to take into account when we're looking at the evidence that supports this. And very importantly, specifically for invasive strategies, and when you plan to refer a patient for that, is the fact of risk stratification, which started with the diagnosis as so beautifully shown by David Newby, and then, of course, medical management with several options, and then, of course, hopefully, when needed, invasive strategies. And what is our rationale and our goal in myocardial revascularizations, especially in a patient with stable coronary disease? And it really is for the relief of angina, therefore dealing with the symptoms, and secondly, improving prognosis. As it was already stated, this is what we want to do. And have we established that with the current regimens we have available? Because we still do have patients with refractory angina at the end. But I think we've done a tremendous job over the last bunch of decades. The current guideline-based medical treatment is suggested in all patients with ischemic CAD or stable CAD, but the truth is that less than 50% become angina-free at 1 year, and we have this from several studies, especially one shown by Bill Weintraub in the New England Journal. And the guidelines currently recommend myocardial revascularizations for our patients with stable ischemic heart disease in presence of flow-limiting lesions and, of course, symptoms, angina, angina equivalent, or those who are unresponsive to medical treatment. And the severity and the plaque vulnerability, if you will, are strictly correlated, as we have seen, but there's no question that we have non-obstructive lesions who can be also prone to rupture, and therefore the question remains, how do we go about controlling or bringing down the future clinical events in our patients? The algorithm was already shown. Really, the truth is that the guideline-directed medical therapy allows for the patients to go through the symptoms, go through the optimal medical therapy, and if then that's not successful, we start to begin to recommend revascularizations to improve symptoms. But the truth of the matter is, and this is the ugly truth, that anti-anginal agents, while they're an alternative perspective, a very important early point is that most patients with guideline medical treatment with the ability to affect hard endpoints is really very much limited. And that's limited to aspirin, statins, ACE inhibitors, and lifestyle modification. And if we look at the majority of the anti-anginals, like beta blockers, nitrates, calcium blockers, and ranolazine, as we've seen already, there was really no benefit in the hard outcomes, unless for beta blockers in post-MI or low ejection fraction. And frankly, there's no question we have issues with patients regarding their side effect profile, but very importantly is the adherence to these guideline-based treatments that are extremely difficult for our patients. What we know about revascularization, if we can improve quality of life, and this is in the most difficult of all of the patients, in patients with diabetes from the FREEDOM study where quality of life was measured, and we have many of these data to show that revascularization treatments, whether PCI or CABG, both have shown to improve quality of life in a durable fashion all the way through. And we also know from the COURAGE data that there's no question that there's crossover from optimal medical treatment arm onto the invasive arm in the patients. And if you really look at the crossover rates, whether it's daily, weekly, monthly, or none, you can see that there's no question that there is this crossover rate that has that does occur, and patients do move over. We also know, this is work by Stefan Windecker in the British Medical Journal, where he looked at the very hard endpoint of all-cause mortality in 100 randomized clinical trials, close to 100,000 patients, and basically with large follow-up showing that revascularization strategies over time compared to optimal medical therapy, the favoring is towards the revascularization therapy in patients with stable coronary disease. And in fact, if you look through the generations and the decades as we have progressed with early PCI techniques, early generation DES, and now the newer generation DES, where we do know that the safety profile of these treatments have improved, this really shows that the point estimates lie in favor of revascularization and reducing mortality. But now, having said that, we really do not have a single trial that has actually shown that there is a reduction in the hard endpoints of death and MI when you compare PCI or revascularization versus optimal medical therapy. I also, this was already shown regarding the CAD prognostic index, that there's no question that there's a correlation with the severity, or if you will, burden of coronary disease with the number of vessel disease involved. And so coronary angiography, or however, whether it's CT angiography or coronary angiography, stress testing, if we can understand the burden of coronary disease, there's a tremendous correlation with the 5-year survival. And as you can see, we begin, as soon as we go into a 2-vessel disease involving more than 95% blockages in 2 areas, we start to reduce our 5-year mortality now beyond less than 90%. So, and we can move as low as 60% in patients with 3-vessel disease, especially when the proximal left anterior descending artery is involved. So anatomy becomes extremely important, not just to know where the lesion is, but to much better understand what is the burden of atherosclerosis in these patients. And the current risk assessment, as you know, and it was already shown by David Newby earlier on, does show this very important algorithm that does go through the different scenarios of finding the best patient who is the candidate for revascularization treatments by going through both the diagnostic and some of the optimal medical therapy treatment, and really looking at the pretest probability, but also understanding what is the whether or not the test is suggesting a high-grade stenosis in more than one area or one territory of the coronary artery disease. So certainly, again, we come back to the assessment of coronary lesions that are considered for revascularization. And this, to me, is one of the most important impacts that the last 5 years has taught us regarding what we need to do after we do angiography and assess the coronary anatomy, because it is just not enough, and that it is a combination of anatomy and physiology that really does dictate who is the best candidate and which vessel territory needs revascularization to enhance outcomes, so that we go back to the original goal of reducing symptoms and improving prognosis. So no question that currently invasive coronary angiography is the gold standard, and maybe David Newby disagrees with me, but at the moment that's where we're at. But once you assess the anatomy without the functional significance of that lesion, of understanding whether or not that particular lesion is producing ischemia in the territory, I don't think you should be proceeding to coronary intervention, especially in a patient with stable coronary disease. And therefore, we have so much work now with fractional flow reserve and the FAME study that basically showed that a PCI that was guided by physiology and not just anatomy had an important reduction in the hard outcomes that was presented at this meeting out to 5 years from the original FAME study with angio-guided PCI versus FFR-guided PCI, where we did see that with FFR-guided PCI, we used less stents, we treated the lesions that needed to be treated, and most importantly, we reduced hard endpoints of death, MI, and recurrent ischemia. And so certainly in patients especially in whom the severity of the lesion is somewhere between 40 and 70%, a luminogram of an angiogram is not your answer, and it is really important to assess the physiology of that territory. And at the moment, we also have IFR, which is an alternative to FFR, where flow can be used without inducing hyperemia, if you will, using adenosine. And it does have a comparable diagnostic accuracy and allows the avoidance of maximal vasodilatation with adenosine and hyperemia. But I can tell you that at the moment, FFR is the gold standard for assessing the severity of a lesion and assessing the lesion that is suitable for revascularization. But let's go and see what are we seeing and in the different variation of the use of cardiovascular testing for adults. And frankly, what we see that even in the first incidence of heart failure in patients, and David, I'm sure you're well aware of this, that actually the important anatomic evaluation of a patient is rarely done in the first incident of heart failure. And although our guidelines suggest otherwise, that we should at least understand what's going on, this is not what is happening in regular hospitals. And here's data from anatomy data from cath labs in Ontario. And if you look at that compared to the New York State, with 54,000 patients here in Ontario, about 18,000 patients, if you look and see what they're seeing from their registry data on patients who had no heart history undergoing elective cath, you can see that they are finding some coronary disease, and some of those are quite severe in the different territories, as you will. Before anyone is thinking about a revascularization strategy, I already talked to you about the FFR guidance and understanding the physiology of the territory. But it is really important to better understand the importance and the incidence or the burden of ischemia on that patient. And unfortunately, FFR shows you the lesion physiology, but I do believe that stress testing is extremely important, both by either whether it's with MR, whether it is with nuclear testing, to really help you with ischemia. And for revascularization to reach its goals of reducing ischemic symptoms, but importantly improving prognosis, ischemia plays a very, very important role, and the burden of ischemia is extremely important. And that is the reason why we now have the ischemia large NIH trial undergoing with Judith Hochman and Dr. Mehran leading this to see how we can evaluate the right patients and whether or not optimal medical therapy versus revascularization is going to work in these patients who have ischemia. So what about the technique? Where are we with the technique of revascularization? I'm glad to tell you that the last 2 decades have been an incredible 2 decades for interventional cardiology. At the moment, we have new generation drug-eluting stents that are the standard of care in most of the patients undergoing PCI. And the data that you have from the previous trials of comparing CABG to PCI is really old PCI, and the field of interventional cardiology is moving almost faster than the speed of what we can have available to all of you as far as evidence. There's no question that the arterial conduits on the CABG side have definitely improved outcomes, and the move is moving towards more and more towards total arterial revascularization from our surgical colleagues, and that's incredibly important, showing patencies of greater than 90% over a 10-year period. And at the moment, also, radial artery conduits have a much better longer-term patency compared to saphenous vein grafts, and the move is towards a total arterial revascularization. But irrespective of whether or not is PCI or CABG, there's no question that complete revascularization should be our goal, especially in patients with multivessel coronary disease and ischemic heart disease in stable coronary disease. And we showed from the CONFIRM registry the association of revascularization and all-cause mortality, showing an improvement, especially when you have a higher burden of cardiovascular disease, more importantly in the SEC2 and 3 vessel disease, and certainly an improvement in left ventricular ejection fraction, especially in those patients at high risk with high burden and severe stenotic lesions that are producing ischemia. And this is shown from the PROTECT 1 and 2 studies showing pre-PCI and follow-up improvements in left ventricular ejection fraction, even in the very high-risk patients. And certainly in the current era of improved techniques, assessment of appropriate use criteria, and making sure that the right patient is receiving the right procedure at the right time is the goal of all of us in the revascularization and all of us as clinicians. And I think that we're seeing more and more that appropriateness is fitting into the high-risk features in the complex patients for most of those as far as revascularization is concerned. I show you this slide again from that meta-analysis supporting this idea with revascularization therapies showing an improvement in all-cause mortality. And we can say that the composition of the current available metallic DES, and now with bioresorbable scaffolds, we're gone from a very, very early anti-proliferative drugs, but early polymer material, to now extremely thin strut, polymer-free almost, or fluoropolymers that are extremely safe with durable long-term outcomes and enhancement and improvement in the current metallic DES. And we look forward to what bioresorbable scaffolds will bring to us, but that data is obviously still scarce, and we await the results of the larger randomized studies. As far as coronary artery bypass, certainly the conduit choice in patients undergoing bypass, if we can, we would love to see total arterial revascularization. This is not possible by every surgeon and in every patient, obviously, but certainly for the left anterior descending and large territories, knowing the anatomy and allowing for arterial revascularization using the bilateral internal mammary arteries, and there was a shift away from that, especially in the diabetic patients due to infections, but this is really a shift backwards now to total arterial revascularization because the durability of that versus saphenous vein grafts are obviously much, much more improved. So where are we with the evidence supporting myocardial revascularization? This is an extremely busy slide, and please refer to the paper for this. From 1964 to 2014, and I would say that's a long time, 50 years of enhancement in our techniques and 50 years of data on myocardial revascularization, going from medical treatments versus bypass surgery to balloon angioplasty era versus bypass surgery, BMS versus bypass surgery, DES versus bypass surgery, and we really now are looking to the future to these two trials, the Acyl study, which will look at the Xience stent in high-risk patients, especially those involving the left main and multivessel disease, and ischemia is the patients who have stable coronary disease with ischemia on their stress test, and they're randomized to optimal medical treatment versus a revascularization technique. Here's another very busy slide, again in the text of our paper that you can find at the booth and hopefully online, and I'm sure you will all go there and download all of this. PCI versus CABG is summarized on this table, a tremendous amount of work, but let me summarize for you that most of these trials versus PCI are favoring CABG, not for the hard endpoint of death and MI, but much more importantly for repeat revascularization where we are not as good as our surgical colleagues. And the same goes in the diabetic patient population, but here in the diabetic patient population with the most recent FREEDOM study, which again compared CABG to first-generation obsolete DES, which is Cypher and Taxis. But having said that, no question that CABG was favored. And here, the hard endpoints of death and MI at 5 years did have a favoring of coronary artery bypass grafting. So the most important here is to be sure that the patient is selected for the right treatment and the right revascularization strategy, but that also a heart team approach is in place so that that kind of a discussion can go on with the patients. It is important that in the specific recommendations for the patients with diabetes, the current guidelines state that revascularization is indicated to reduce cardiac events in these stable patients with a 1 level of evidence B. Importantly, the PCI, most of them should undergo bypass unless there is a very low syntax score, and we'll talk about what that is the severity of the lesion, complexity of the disease, an anatomic index that was put together by the syntax investigators, and it allows a 2A for the very low-risk diabetic patients with multivessel disease. So if we look at the algorithm, the current algorithm across all of the anatomic and clinical subsets of patients with CAD, if we look at the stable coronary disease who have symptoms and myocardium at risk, you can take a look and see that if there is once we know the anatomy and we know where we are with our syntax scoring, we can then evaluate whether or not what needs to be done for the patient and divide them into the subsets of whether the patient should receive bypass surgery versus PCI. And for the most part, the patients with a low syntax score who are not good candidates, low syntax score who are candidates for PCI and adherent for dual antiplatelet therapies should undergo a PCI strategy, especially if the myocardium at risk is large and involving a large territory. Bypass should absolutely be the first line of treatment in complex, high-risk patients with large areas and multi-vessel disease and high syntax score. And somewhere in between is where the heart team makes an important decision based on anatomy, physiology, patient demographics that then will dictate what the revascularization strategy should be. After myocardial revascularization, we must know that optimal medical therapy is really the mainstay before, during, and after. And the current for PCI, the antiplatelet treatment is definitely the mainstay for secondary prevention. After bypass, absolutely, aspirin has been shown to improve long-term outcomes. The usefulness of P2Y12 inhibitors is less well established, although there is some recommendation in the guidelines. No question, to prevent stent-related events, early DAPT is incredibly important, and there's a mandatory period. But when you're thinking about the patient as a whole, with large atherosclerotic burden and outside of the treated lesion, treatment of DAPT is considered, can be considered, and the DAPT guidelines give us that from the European Society, a 2B, to be considered when you weigh the risk of bleeding versus ischemia in those patients. And so very important to avoid the effects of spontaneous bleeding, which is extremely important and not to be forgotten about. The new generation DES, we can reduce the mandatory DAPT duration to a shorter period, which allows for the stent to heal and for the stent-related events to be reduced. So this particular schematic really does show you, for the management of dual antiplatelet therapies, a mandatory period somewhere between 3 to 6 months, most likely up to 6 months in DES, and then beyond that, assessing the risk of bleeding and ischemia and thinking about whether or not the patient should be continued. And if there is a bleeding risk, dual antiplatelet therapy should be stopped to a single antiplatelet therapy. And if not, if the ischemic risk is high and the patient is doing well, you can consider prolonged dual antiplatelet therapies. There are other important emerging strategies of revascularization, if you will, with external counterpulsation. There's actually a guideline recommendation based on a very, very small study. We heard about stem cell treatment and spinal cord stimulation, and certainly very interesting coronary sinus reducer. All of these require further long-term and larger evidence before we can make an important recommendation for those. And lastly, and sadly, I would like to dedicate this work to the loving memory of Ms. Caroline Windecker. Thank you.
I don't think at this late time of the day, if there are any urgent questions, I think we have a couple of minutes to answer these. If not, I would like to thank, first of all, the Lancet for being here at the Congress, and all the speakers for giving a very complete overview of the topic. Thank you very much.
Very good.
Yeah, thank you.
Yeah.